So when we first start, you're going to just kind of ease into listening to how Dr. Cummings talks about the medications, because then it will start all making sense as he moves through it. So without further ado, I'm going to turn it over to Dr. Cummings.
Thank you. I'm pleased to be back. Basically, this is an example of give me an audience, and I'll talk to anybody who doesn't run away fast enough. I do welcome questions during this. In smaller groups, I usually tell people just to talk, because frankly, since I'm blind, if you do this, normally it does absolutely nothing. And in this case, though, Professor Allenson has been kind enough to say if you want to raise your hand, she'll alert me that someone has a question. And indeed, this will be better as a discussion than it will be if you simply listen to me drone on for 2 hours. In fact, I'm not sure I can stand that either. We're going to talk about psychopharmacology today, at least in an overview. This is a little bit like talking about life, the universe, and everything in 2 hours. Because indeed, if we went over this in detail, it would be more a couple of year course to get through. I don't want to start it with just basic definitions. Some of the terms that you'll hear when people are talking about medications, or when you're reading an article about medications related to psychopharmacology. First, the term itself, pharmacology is simply the study of giving compounds or ions to people to treat diseases. Psychopharmacology is a subset of that, essentially those medications used to treat illnesses or diseases that are characterized primarily by mental signs and symptoms, although many of the illnesses we treat do also have neurologic components and other components in the body as well. Whether medication is a member of this group or not is largely determined by the intent for which it's used. Now, some are almost exclusively used to treat mental disorders. Others have more than one use. For example, anti-epileptic medications, if they're being used to treat purely a seizure disorder, would generally not be considered to be a medication that would fall under the umbrella of psychopharmacology. On the other hand, as we'll talk about, many of the anti-epileptic medications are also used to treat things like bipolar illness, which puts it clearly in this category. As I tell people, what medications are indicated for by the FDA is a marketing decision. Basically, a company decides what they can sell the drug for. They do studies related to that indication. They get that label. Frankly, the molecules don't know anything about the labels. They just do what they do, and in some cases we find that they have uses beyond or outside of what the FDA has indicated them for. Other terms that you'll very commonly hear, the very basic ones, are things like an agonist. This is a molecule usually that acts in the same direction as a naturally occurring neurotransmitter. In other words, it generates a signal that's very much like whatever it mimics in the brain, goes in the same direction. We don't have a lot of those. Good examples would be some of the drugs used to treat Parkinson's disease essentially mimic dopamine. Antagonists, things that if they bind to a receptor in the brain, they keep the receptor from acting. They essentially block the activity of that receptor, so they decrease the signal from neuron to neuron. There are also inverse agonists. These are things that act in a direction opposite that which the naturally occurring neurotransmitter does. A good example of this is the molecule flunazamil. If you give flunazamil to somebody who's overdosed, for example, on a benzodiazepine or on alcohol, it will tend to reverse those effects. The opiate antagonists, things like naloxone and naltrexone, used to counteract opiate overdoses, are also examples of inverse agonists. The characteristics of drugs in terms of binding to things. You'll often hear people talk about a drug's binding affinity. That literally is just the tightness with which it sticks to its receptor by static forces. Drugs, for the most part, do not act by chemically changing things in the brain. Instead, they act by binding to proteins, often receptors, sometimes other proteins, and essentially changing either the activity or the shape in the case of receptors. A receptor and a transmitter are kind of like a key and a lock. Once they fit together, they slightly change each other's shape, and that's how they act. Now moving on to kind of page 2 of the handout. Drugs interact with the brain in 2 major ways. There are some exceptions to this, and we'll talk about the exception in terms of particularly the anti-epileptic medications. But by and large, most of the drugs that we'll be talking about act in one of 2 ways. They either produce an immediate change in the flow of charged ions into or out of nerve cells in the brain. Drugs that act in that way produce an immediate effect. For example, if you hook somebody up to an IV and you give them a bolus of lorazepam, a benzodiazepine, by intravenous infusion, the person's eyes will kind of cross and they will become sedated in about 10 to 15 seconds. Because as soon as the drug is present, it produces a change in ion flow. That produces a change in the amount of cell activity, the firing rate of neurons, and the effect is immediate. You can see it right then and there in front of you. Most of the psychopharmacological drugs don't act in that way. Instead, they act by a mechanism called initiation and adaptation. That is, they repeatedly perturb the activity of a neural circuit by binding to a receptor and altering the amount of signal in that circuit. Interestingly, if you do this repeatedly over time, the characteristics of the cells in that circuit will change. They will adapt and will behave differently. That's why you don't see much of an immediate effect. If you give somebody, for example, an antidepressant, the amount of neurotransmitter between cells in the synapse changes within a few hours. You don't see the person, however, becoming less depressed in a few hours. That takes weeks. And that's because what's happening is that the repeated perturbation at the receptor is getting translated into a change in second messenger molecules inside the nerve cells. That in turn is altering DNA transcription and translation in the cell, and ultimately changing the phenotypic nature of the cell, kind of shifting a little bit, so that as it's part of a circuit, that circuit element has changed, which changes other circuit elements down the line. Interestingly, psychotherapies do the same thing. That was most clearly demonstrated using PET scan by Louis Baxter and other researchers in his group at UCLA. He's now gone on to Emory University in Georgia. But what he did is he compared people with OCD, obsessive compulsive disorder, who were treated either with 6 weeks of an SSRI antidepressant, I believe it was fluoxetine, or they have the classic treatment for OCD, response prevention, where you have, for example, in somebody who has difficulties with contamination fears, they touch something they think is contaminated and then you prevent them from washing their hands. Their anxiety level goes up, but people can only sustain anxiety for so long, so it comes down. And if you do that to them over and over and over again, eventually the fear of contamination declines. We understand the circuit that's involved in that fairly well. It goes from the non-dominant caudate nucleus, which is kind of in the middle of your brain. There's a projection to the frontal part of the brain, and then an inhibitory circuit that comes back and shuts off the caudate nucleus. The normal functioning of this circuit is for grooming and orienting behaviors. When people kind of straighten their hair or check their environment, that's that circuit being activated and causing really pre-programmed behaviors to occur. In the person with OCD, the circuit gets stuck in the on position. For example, I had one patient who was an inveterate checker of her front door. She took a trip to London. She got to Heathrow, turned right around, flew all the way back to LA because she had to check the front door one more time. In response to either the SSRI antidepressant or response prevention, that circuit's activity level declined by about the same amount. Interestingly, if you gave the person both an SSRI and response prevention, they were additive. So you could boost the amount of the overall effect. The point of this, though, simply being that initiation and adaptation can occur from medications, but it can also occur from repeated episodes of a whole variety range of psychotherapies. So in that sense, everyone in this field is essentially trying to do the same thing with respect to altering brain function, that is, getting circuits to adapt back toward a more normal level of signaling or transduction or activity, thereby improving the symptoms of the illness. So, any questions so far? No? Okay. Well, I've either been entirely...
There is one now.
Okay. I started to say I was either entirely boring or completely clear.
So you were talking about how the SSRI antidepressant affects the nature, the phenotypic, is that what you said, nature of the cell?
Yes.
And I was wondering, so when, you know, the pharmacological, when the medication ceases, does that cell go back to being?
In
Does
many
it change, or do they develop new pathways, or?
It depends on the nature of the illness. Now, in the case, in the example I was giving with obsessive compulsive disorder, the answer is usually yes. If the person discontinues the medication, if the medication was the only treatment, they will tend to drift back to their baseline state. That's not true of all illnesses, and illnesses come in different types, if you will. If they've had response prevention treatment, they will tend to drift back, but not completely to baseline. And in part that's because most of the behavioral therapies, to some extent, get carried on in the person's life well beyond the end of the formal treatment. Most behavioral therapies include training the person to some extent how to continue doing the treatment themselves, whereas obviously with a medication, once you stop taking it, it washes out over time and is gone. In OCD, that usually will let the person drift back to baseline. In other illnesses, not so much. Now, it depends on whether the illness is chronic in nature or recurrent in nature, or is more a one-time thing. For example, if somebody has a major stressor and is treated for depression with an antidepressant and they recover, current treatment recommendation is to continue the antidepressant for a year and then taper it to see if they actually still need it, and in many cases they don't. If somebody, however, has recurrent depression, they come from a family that's genetically prone to depressive illness and they've had 3 or more episodes of major depression, the recommendation there is to continue the antidepressant essentially indefinitely, because their odds of relapsing if the antidepressant is stopped is pushing 90+%. So it depends on the nature of the illness. Okay, moving on a bit, we're going to go through medication classes, and I'll also throw in information about the major illness that's usually related to that class. We're starting with, you have to realize psychopharmacology is a relatively new field. Before the middle of the 20th century, for the most part, psychopharmacology did not exist. The barbiturates came onto the market in 1903. There wasn't really another major pharmacological advance until 1950. The first major drug that came along was a derivative of a very common drug. In fact, something you've probably all taken, Benadryl, generically known as diphenhydramine. It was the first antihistamine. It was synthesized in 1946, right at the end of World War II. One of the derivatives of this was chlorpromazine. Thorazine is the trade name. It was the first antipsychotic. It was not discovered as an antipsychotic, however. A French physician named Denneker was looking for a preoperative medication that would make people less anxious and wound up about having to have surgery. In other words, he was looking for a preoperative drug. He wanted something that was a little bit sedating, would kind of calm people down. And indeed, chlorpromazine would today be known as a surgical drug, except that it also lowers blood pressure very effectively. The first time they tried this in a volunteer psychiatrist, a Dr. Corti, he was telling Dr. Denneker, yeah, I feel better, it's calm, I don't have any concerns. And then he stood up to go to the bathroom and promptly fainted and went face down on the floor. At that point, they figured out that the drug was also very good at lowering blood pressure, which it flopped as a surgical drug at that point. Denneker, though, said, well, you know, these people we have in St. Anne's Asylum are pretty wound up. They're kind of anxious. They're kind of really out there. Maybe we could use it just as a sedative. So they tried it. And indeed, they found not only was it a sedative, it produced a reduction in psychotic symptoms. At least positive psychotic symptoms, things like hallucinations, delusions. That was quite exciting because up to that point there had been no treatment for psychotic illness at all other than to confine the person. They were rather amazed. They didn't quite know how to use the drug at first. They were giving it intravenously every few days, and believe it or not, they actually got people better that way. By 1954, chlorpromazine had spread worldwide. Because Denneker kind of ran around to different conferences going, this is great stuff, something entirely new and different. And indeed, it was introduced into North America via Montreal. Denneker was French, so he went to Montreal to a conference that spoke French. It spread into the US and very quickly set off an explosion of research for similar agents. And indeed, the table that you have on that page is a list of the more common first-generation antipsychotics. The generic name is on the left, the trade names are on the right, and that'll be true for the rest of the tables in the handout. There were a whole different groups of chemical classes. The chemical classes, frankly, are not important. These drugs all act exactly the same way. They bind to dopamine receptors, D2 especially. There are 5 types of dopamine receptor in the brain, cleverly labeled by neuroscientists 1 through 5. The target in this case is D2. The overactivity of D2 receptors in the temporal lobe of the brain is what is responsible for generating positive psychotic symptoms, things like delusional thinking, hallucinations, some of the psychomotor agitation observed in schizophrenia. These drugs all bind to the D2 receptor and block signal transmission. That has the effect, essentially, of modulating these receptors. Now, it's a pretty crude form of modulation. It's kind of like taking a Swiss watch and hitting it with a hammer. The watch is still right twice a day, but it doesn't really keep very good time. So it was a crude intervention, but highly effective in people who were very psychotic, especially those at the time who were drug naive. Unfortunately, people do tend to become resistant to antipsychotics over time. These drugs were not all the same in terms of side effect profile. The very high potency ones are more likely to cause extrapyramidal symptoms, muscle stiffness and such. The low potency ones, just like chlorpromazine, all lower blood pressure. They're very anticholinergic, so they cause dry mouth, dry eyes, constipation, all of those side effects. And long-term risks include things like tardive dyskinesia, involuntary movements, because these receptors become sensitized if you block them chronically. And in a few rare cases, you can cause something called neuroleptic malignant syndrome, in which the person loses the ability to regulate muscle tone or to regulate body temperature, so they become exceedingly febrile. The muscles become rigid to the point that they begin to break down, which the release of myoglobin, a major protein from the muscle, can cause renal failure. Luckily, that's a rare adverse effect of these drugs. As you can tell, while these were a major advance over nothing, they still left a lot to be desired. They were, in many cases, very difficult drugs to tolerate. They produced tardive dyskinesia, involuntary movements, at a rate of about 3 to 5% per year of exposure, up to about 60% of people. Most often, things like pursing of the lips, tongue thrusting, not very pleasant side effects. Luckily, 94% of tardive dyskinesia is mild and stable. 6% can become progressive to the point of being crippling. That prompted people to look for something better. And indeed, the very first, and this is the next page, the second generation antipsychotics. The very first second generation antipsychotic was actually synthesized only 8 years after chlorpromazine in 1958. This was clozapine. It was initially missed as an antipsychotic because it did not produce stiff mice. In the 1950s, when they were researching these drugs, receptor assays, MRI and MRS scans did not yet exist. We didn't have the ability to image the brain very well. We couldn't look at the number of receptors. We couldn't tell what was bound to the receptors, all of which has changed. At that time, the way that you looked for a potential antipsychotic is you gave it to a mouse, usually by giving it an injection into the abdominal cavity. If the mouse got stiff, you had a potential antipsychotic, because they knew that blockade of dopamine, which is involved in muscle tone as well as thinking, was the mechanism by which the first generation antipsychotics exerted their effect. If you didn't get a stiff mouse, well, too bad. So what they did is Wander Pharmaceuticals, who owned clozapine at the time, put it back on the shelf and said, well, not sure what it is, but not an antipsychotic. A few people were intrigued with it and kept doing a little bit of work during the 1960s, and indeed demonstrated that it did have antipsychotic properties despite not making stiff mice. That ultimately led to some trials in which it was compared to other antipsychotics, and indeed they discovered that people who were not responsive to first generation antipsychotics at all, meaning they were refractory, you gave them Haldol, you gave them Thorazine, and nothing happened to their psychosis, 60% of those people would have a marked response to clozapine. So they figured, oh, it's not acting via dopamine, but it's certainly doing something. That led to it being released, and frankly, it would have replaced all of the earlier antipsychotics, except that 6 people in Finland up and died in 1975 because they had no white blood cells, at least no granulocyte white blood cells, and they died of overwhelming infection. At that point, they realized that the drug had the capacity to produce agranulocytosis, loss of your cells that are responsible for fighting off bacteria. That led to the drug vanishing from the market until it was reintroduced in 1989 with a whole list of monitoring requirements for CBCs and for other potential adverse effects from the drug. It did set off, however, research looking for other second-generation antipsychotics, which now there are several families. There's the clozapine family, as you might guess. It had children. Olanzapine, quetiapine, acenapine, collectively known sometime as the pine family. Another drug that was more similar to haloperidol, but was a little different, was risperidone, which is, of course, also generated a whole family of drugs. Haloperidone, iloperidone, ziprasidone, such that those have now become known as the Done family. And there is now a third group, which are different. The clozapine acts primarily not by dopamine, and it's unique, it's very different. It actually acts by modulating glutamate transmission in the brain, different neurotransmitter, and is the brain's major on molecule. Glutamate is what makes your neurons sit up and do tricks and think and activate. Clozapine actually increases the amount of that neurotransmitter, which is likely why clozapine has benefits for both positive and negative symptoms of schizophrenia, whereas the other drugs, not so much. They're very much better with the positive symptoms than the negative symptoms. One of the chief differences in terms of dopamine blockade with the second-generation drugs, though, is that they bind much more loosely to dopamine receptors, so they don't cause EPS nearly as much. It's about at a rate of about 1/10. Unfortunately, particularly the pine family is very good at blocking or antagonizing insulin receptors, which is a setup for dyslipidemia, obesity, diabetes, collectively known as metabolic syndrome. So unfortunately there's no, well, that's a terrible pun, but no free lunch. Such that, nothing comes without adverse effects. The last group of antipsychotics that has been developed are the partial dopamine agonists. These drugs stimulate activity in the same direction as dopamine, but only about 1/4 as much. Their advantage is that if you have too much dopamine, it brings the signal down. If you don't have enough, it brings it up. And in schizophrenia, while we were talking about the temporal lobe having too much dopamine activity, the frontal lobes actually don't have enough, which is why often what you'll see in schizophrenic patients is, in addition to the positive symptoms of things like hallucination, you'll see deficits in verbal fluency, cognitive deficits, cognitive inflexibility, that kind of dulling of ability to think. That's not enough dopamine in the frontal lobe. So these drugs provide a way of boosting it in one area and reducing the amount of signal in another. One of the things that has changed is psychiatrists have stopped thinking about these circuits in terms of the absolute amount of neurotransmitter and have started thinking about them more in terms of, well, how much signal is there? How much talk is there between one neuron and the next in the circuit? Because it seems to be the rate of signal transduction and keeping that within normal boundaries that is key to treating these illnesses. Now, are any of these a cure for schizophrenia? No. And the reason for that is, one of the reasons we get such a limited response is that this is an illness that starts during the second trimester of pregnancy with abnormal migration of neurons. They don't go to the right place. They don't line up in nice little neat rows the way they're supposed to. Because a lot of the genes, the genetics that underlie this illness are genes that control the distribution and orientation and connecting of neurons one to another. Those things are abnormal in the schizophrenic brain. As a child develops who's going to become a schizophrenic, they exhibit mild behavior abnormalities. Now, unfortunately, they're not good enough that people can spot them going forward. They've done studies in which, if you look at children, say a group of 5, and you tell the researchers one of these 5 is now a schizophrenic, about 80% of the time they can tell you which child it is. Unfortunately, we're not good enough to do that forward. If we were, there is a possibility that we could prevent some of the neuronal and connective loss that occurs as part of this illness. We've come to think of schizophrenia much more as essentially a developmental dementia. You know, they're end-of-life dementias like Alzheimer's disease. People lose neurons, they lose connections. Well, in this case, they're losing them at an excessive rate during development. For all of us, we're born with about 2 to 5 times the number of connections between neurons that we'll have as adults, and a large part of maturation in the brain has to do with selecting out those circuit elements that are useful, that fit the environment. In fact, the environment actually helps to select which neurons are kept and which ones are discarded, by which circuits are stimulated and which ones aren't. In the schizophrenic brain, though, there's an excessive loss to the point that by late teens, early adulthood, the connections have been lost to the point where processing of information starts to get fragmented. A good analogy would be if you took a pair of wire clippers and sort of randomly clipped a wire here and there in your computer, eventually things would not work very well. And that seems to be what we're seeing in the developing schizophrenic brain. A very fascinating area of research now is if we could use low-dose antipsychotics in children from a very early age, if they were destined to become schizophrenic, the question is, would it prevent the illness? Most of this research has been done in Australia, where they've taken children who have 2 schizophrenic parents, so that their genetic likelihood of developing the illness is between 40 and 50%, very high-risk group. They put one group on placebo, sugar pill every day, put the other group on either a 0.5 milligram of risperidone, very, very low dose, much lower than you'd use to treat active psychosis, or 2.5 milligrams of olanzapine. So far, they haven't completed these studies because they need to follow these people until they're in their late 20s. So far, the placebo group, 37% of the children have become schizophrenic, meaning overtly psychotic. In the treatment group, about 7% have become psychotic. Eventually, we may know from studies like this whether we can actually prevent this illness if we can figure out how to detect it early enough. Because frankly, our treatment presently is we're kind of closing the barn door after the horse leaves, which is why our treatment response to medication is more limited than we would like. Questions about the antipsychotics or schizophrenia?
Yeah, Heather in the back.
The dyskinesia, is it reversible when after someone's been treated with medication over time and they develop it? Can it be reversed?
It depends on how long it has been present. One of the things that occurs, well, a couple of things occur with tardive dyskinesia. There is an increase in the number of dopamine receptors, which means then if any dopamine leaks through, it sets off a bigger than normal response, which is what generates the movement. But there is also oxidative damage to the receptor, because one of the effects of the antipsychotic medications is to slow down the normal rate of turnover and replacement of receptors. Receptors live in a harsh environment out on the cell surface. They get bombarded by things that will cross-link proteins. Normally that's dealt with by the cells by always having kind of a turnover going on where the receptors don't stay out there very long. When an antipsychotic is present, they sit there for a long time. They get damaged. Then even if you take the antipsychotic away, the cell seems to have lost some of its normal plasticity, such that often the dyskinetic movements don't go away completely if the person has been on an antipsychotic for an extended period of time. Basically, Dilip Justi, who was at UC San Diego, did an excellent study in which he found that if people had dyskinesia for less than 5 years, and the antipsychotic was either switched to something that was a less robust antagonist, or they were able to stop the antipsychotic altogether, those people stood about a 50% chance of the TD simply going away over time. If the tardive dyskinesia was present for longer than 5 years, the number of people who recovered got smaller and smaller and smaller, largely because that plasticity had gone away. We do have a couple of new drugs coming on the market. Well, not new entirely. Tetrabenazine, which depletes dopamine, has been used for eons to treat Huntington's chorea. It has become generic just last year, and likely you'll see some people with more severe tardive dyskinesia get treated with it, because if you can reduce the amount of dopamine that's available, it will help treat the movements. There are 2 analogs of tetrabenazine that are likely will be coming to market next year that have some kinetic advantages. You don't have to give them 3 times a day like you do tetrabenazine to treat TD. So the treatment possibilities for TD will likely be improving in the fairly near future.
You have another question, Heather?
Okay, so can you tell, I see a lot of clients who come in and they are being treated with Abilify for depression. And can you explain the mechanism of maybe how that works? And a lot of them I see, I've had clients come in from a primary care doctor, and that's the first quote antidepressant they've ever been on.
It likely should not be the first antidepressant. And in fact, that's I noted that while the second generation drugs are less likely in the individual patient by about 10-fold to cause tardive dyskinesia or EPS, the actual overall population rates of EPS and TD haven't shifted that much because now people are using these drugs more widely. Where aripiprazole and some of the other second generation antipsychotics are beneficial in depression is as an augmenting agent. If you have somebody on an antidepressant and they have a partial response, but you just can't get them good enough, a drug like aripiprazole may give you a boost in depression. And for aripiprazole, the likely mechanism is in the depressed brain, there is an actual deficit in dopamine transmission. Being a partial agonist, you're likely raising that amount of transmission up. Most of the antidepressants that we have, and we'll talk about this, increase either serotonin or norepinephrine signaling. Most of them do little or nothing for dopamine. So the aripiprazole likely is acting as an augmenting agent by pushing that third catecholamine neurotransmitter up a little bit.
Okay.
But it should not be the first, quote, antidepressant.
Amen. Thank you.
It should not be, in fact, it should not be used as a solo treatment for depression. Okay, and with that, why don't we indeed move on to the antidepressants, starting with the most popular group currently, the SSRIs, or selective serotonin reuptake inhibitors. These drugs account for about 70% of all of the antidepressant prescriptions in the United States. They are not historically the oldest, but they are certainly the most popular, and that's because they are much safer than most of the first generation antidepressants. These drugs, as the name suggests, act by relatively selectively increasing serotonin by blocking its reuptake. The catecholamines and indolamines, serotonins and indolamine, norepinephrine and dopamine, or catecholamines, are inactivated not so much by being broken down once they're released by a nerve cell, but by actively being pumped back up, repackaged, and then retransmitted. It's an excellent example of recycling at the cellular level. Which is good, because actually, if that recycling didn't occur, the cells that we're talking about can only replace about 10% of the molecules they use for signal transduction. So if all of these were going out and being destroyed immediately, we'd all run out of these fairly quickly, and presumably we'd all then be depressed. So these drugs act by binding to that reuptake pump, which is a protein. It sits on the presynaptic cell and literally vacuums serotonin or norepinephrine or dopamine back into the presynaptic cell, where it gets repackaged and then gets reused. These drugs slow down that process and thereby leave the neurotransmitter, whichever one it's specific for, out in the synapse longer, so it generates a bigger signal for the next cell in the circuit. The SSRIs act within a few hours, as we're talking about. The level of serotonin goes up 4 to 5 hours after the person begins taking the drug. But they don't become undepressed that quickly, because as we talked about, this is an example of initiation and adaptation. The next cell in the circuit will downregulate its cell surface receptors in response to the increased serotonin. That will alter the amount of second messenger proteins generated in that cell. And that ultimately actually changes the expression of DNA in that next cell in the circuit. And that process goes on as kind of a cascade down the different cells that are involved in the limbic circuits that modulate mood. We've changed the conceptualization of depression and its treatment. It used to be that people thought there was actually a deficit of serotonin or a deficit of norepinephrine in depressed people. Well, it turns out that's not true. When we gain the ability to measure these things, those depressed people have normal amounts of neurotransmitters sitting there. The problem seems to be that the limbic cells, the cells that these things are trying to modulate, have gone outside of their homeostatic boundaries. They're kind of failing, and it reaches the point where these, at their normal levels, can no longer provide an adequate stimulus. And so the person becomes depressed. There's actually then a 30 to 40% decline in brain metabolism. So depression not only is a reference to mood, but actually metabolic rate in the brain, the rate at which brain cells uptake oxygen, synthesize things, and go about their business of generating nerve signals. So the depressed brain really is depressed. These drugs act by repeatedly perturbing those cells, trying to push them back toward normal. And in cases where people respond, that works over about 4 to 6 weeks. Again, because we're working at something from the outside, trying to perturb it and make it change, Our success rate is less than we would like it to be. Almost all of the antidepressants, if you look at their trials, about 2/3 of the patients typically will get at least a 50% reduction in depressive symptoms. Frankly, if I were severely depressed, I might be happy that I got a 50% reduction, but I wouldn't be all that pleased that I was still moderately depressed. Only about 35% of people with major depression get a full remission from antidepressant treatment. And that's especially true if they've had repeated episodes of major depression, meaning that they are genetically loaded in the direction of being depressive. In fact, you can see this if you look at the epidemiology numbers for depression. If somebody is just in the general population, their risk of having an episode of major depression in their lifetime is about 6 to 8%. If somebody, however, has one episode of depression, and we're not talking about minor having the blahs, we're talking about major depression with all of the neurovegetative signs and symptoms, their odds of having a second episode is about 50%. If they have two, the odds of episode number 3 is up to about 65 to 70%. If they've had 3, the odds of number 4 are about 90%. That's why the recommendation that if somebody has recurring episodes of depression, they may need to be on an antidepressant long term, which is, the SSRIs have been a very nice introduction for that because they are far safer than many of the older antidepressants. That doesn't mean that they're absolutely safe. There is no such thing as a safe medication. If the only medication I've ever seen that has absolute safety is also something that is absolutely inert. If it does something, it comes with some kind of danger. And indeed, in terms of side effects, the SSRIs are not free of risk. They are very good at causing sexual dysfunction. Now, if you look at the package inserts for these drugs, it'll say 5 to 7% prevalence rate for sexual side effects. Those numbers came from just people who spontaneously volunteered that they were having trouble. When they went back and actually asked people, is this causing you problems? The rates are actually closer to 60 to 70%. So clinically, an important point is if somebody's being treated with an SSRI, it may be kind to ask them, is this causing an impairment in sexual functioning? Usually delayed orgasm or anorgasmia, because there are ways of getting around that. Indeed, vilazodone and vortioxetine, two recently introduced SSRIs, because they also have additional mechanisms of action, stimulating 5-HT1A serotonin receptors. Their prevalence rate really is down around 5%. So switching them may be a kind thing to do. These drugs are also problematic in pregnancy. They decrease the rate of fetal growth in the 3rd trimester. They also produce about a 2-week earlier delivery. And in older people, they cause a loss of bone mineralization. So you can increase the rate of fracture, hip fracture in particular, in older patients if they're kept on high-dose SSRIs through late to middle life. So again, no free lunch. There is also a limitation on efficacy for the SSRI antidepressants. They are very good at treating depression. They've become also, as we'll talk about, the most common treatment for anxiety disorders, including things like PTSD, obsessive compulsive disorder. But they are not as effective an antidepressant as some of the mixed mechanism agents are. So that if you have somebody who has failed 2 SSRIs for depression, it may be time to think about something that pulls norepinephrine into the mix as well. Which brings us to the heterocyclic antidepressants, the next group. This includes both old and new drugs.